A question about the Haiti. I was actually on the ground sending people out to you, the ship, and we were certainly thrilled when that ship arrived. One of the questions I have is with the pediatric patients. One reason you may not have seen as many is that we actually were told not to send most of the pediatric patients out to that ship because of repatriation problems. We had a Swiss orthopedic pediatric team that showed up at Huey about the same time that the Comfort showed up, so we started having the pediatric patients taken care of there. What repatriation plans do you have when children do go out to the ship? Because a lot of them actually did have parents, but they weren't allowed to have the parents go, and there's a real concern of getting those children hooked back up to their parents.
So on the Comfort, we were actually, one parent was allowed to transit with a child. And as far as that was the standard on shore, the repatriation of the children on back to in country was with UNICEF, is primarily who we worked with to make sure we identified a parent. Again, a country where there's no cards that you can carry to say this is definitely my child. We also wanted to make sure we brought definite parent with definite child together. So again, working primarily with UNICEF as well as other NGO groups.
That was you got all our great panel. Excellent presentations. My biggest, Rob Rush, Chief of Department of Surgery at Madigan Army Medical Center. And my biggest concern is keeping surgeons like you all in the Army. And I know Major General Holly Bolin, I know that is your one of your biggest concerns also. But what is it going to take, other than these great experiences that you're having, and a pretty good lifestyle when we're at home? But what is it going to take to keep stars like Rob Lim and Matt Ritter and all you guys in longer than your obligation? And not only longer than your obligation, but how can we keep you in until a complete retirement? And is that necessary, or should we be concerned about that? Because I'm always wrestling with that, especially at when I have to deploy half of my staff, and all I have left are some very highly skilled civilian surgeons who were in the Army, who retired, but they're working for a lot less than what they'd be making otherwise. Do you have any comments on that, any of you?
I'll comment, Rob. I'm not sure I could stay in longer than my commitment at this point. I still owe the better part of another decade, having spent 20 years already. But in all seriousness, and my opinion is that the biggest impact on retention is, for surgeons anyway, is more, I think, and you can comment on this, frustration with practice in between deployments in terms of generating patient volume, generating interesting patient volume, this kind of thing, to sustain your subspecialty mission versus your your broad mission when you're deployed as a general trauma surgeon. For me, making the peacetime practice enjoyable and fit a sustainable academic subspecialty model is probably the biggest key, I would think.
One of the problems we have is getting that retirement population back into the hospitals to build that practice for the academic centers. One of the things we've been working on is, one, increasing the dwell time at home between deployments, especially for the surgical specialties. And Russ Martin and I have been working on that. And so, as I said, we've been shuffling that. One of the things the Army is now doing is opening up community-based primary care clinics, primary care patient-centered homes. And we've opened that in several areas, and we funded several this year, and then they're going to go on and fund them. What that does is it puts primary care where beneficiaries, active duty beneficiaries, are living. That pulls that population out of the medical centers and the other MTFs. And is what I see that as an opportunity, because one of my big teaching hospitals is Bragg. That makes room in the MTF to pull back in that retirement population, which is the only place they can be seen, so that we can increase that population for GME. And that's what I'm trying to do at my academic centers, to pull in that population so that I can generate that academic population for my surgeons and my other programs to keep those healthy and viable. And that's what, because academics, in my view, is what keeps my folks in, is being able to practice and teach residents. That's been my card, to keep folks in.
We'll probably stop the session there. We're about out of time. But I want to thank everybody for coming and supporting our group. And again, thank our very distinguished speakers for their excellent talks. Thank you very much.